Now invite Dr. Soumya Sucharita to present A Tale of Tolosa Hunt Syndrome.
Good evening, everybody. Myself, Dr. Soumya. Today I will, sorry. Tolosa syndrome is a rare idiopathic inflammatory granulomatous condition caused by non-specific inflammation of the cavernous sinus, orbital apex, or superior orbital fissure. Non-specific inflammation within cavernous sinus or superior orbital fissure is the cause of painful ophthalmoplegia and multiple unilateral cranial nerve deficits. Aim is to evaluate and manage a case of Tolosa syndrome and to rule out other differential diagnoses. So coming to the case, a 23-year-old female presented with severe frontal headache with double vision for 3 weeks. Headache was sudden and onset and associated with blurry vision. Headache was followed by double vision, which was progressive and associated with drooping of the right eyelid for 1 week. So coming to the ocular examination, visual acuity in right eye was 6/9, pupil was sluggish, appearance was proptotic and eyelid was ptotic. The MRD1 was found to be 0.5 mm and extraocular muscles were all restricted in all gauges but more in elevation and in abduction. Cornea conjunctiva were found to be within normal limit and in left eye all the parameters were within normal limits. So coming to the 9-gauge diagnostic position of the gaze, we can see all the muscles were restricted in right eye. So coming to the differential diagnosis, they can be Tolosa syndrome, sarcoidosis, lymphoma, GCA, meningioma, metastasis, tuberculoma. So we did some laboratory tests. So we found that RBS was 140 milligram per DL, TSH and CRP were found to be normal, ESR was raised, ANCA and FP culture was found to be negative. And on MRI, right orbital apex and adjoining cavernous sinus thickening and enhancement of extending till orbital fissure was found. So after a preliminary diagnosis of Tolosa syndrome, the patient was started on 5-day course of high-dose intravenous methylprednisolone, that is 1 gram per day. A dramatic improvement in her extraocular motility deficit occurred. The patient was subsequently transitioned to prolonged oral steroid taper beginning from 60 milligram per day and successfully being tapered up. So the criteria according to the ICSD for Tolosa Hunt was unilateral orbital or periorbital headache, granulomatous inflammation of the cavernous sinus demonstrated either by MRI or biopsy, paresis of one or more ipsilateral, third, fourth or sixth nerve palsy, and evidence of causation, that is headache is ipsilateral to the granulomatous inflammation and headache was preceded the paresis of third, fourth and sixth cranial nerves. So to conclude, Tolosa syndrome is a diagnostic of exclusion and requires advanced imaging and laboratory investigation to corroborate the diagnostic suspicion. Unilateral periorbital headache associated with third, fourth and sixth cranial nerve paresis should ideally be investigated with full workup and comprehensive brain MRI since the first attack. In case with negative brain MRI, spontaneous resolution should be considered and watchful waiting might be advisable before starting the steroid therapy. These are my references. Thank you.
What is the, why does pain occur in Tolosa? Why do you, what is the nerve that is?
Because of the inflammation, that is why the pain occurred.
See, the third nerve, fourth
Yes.
nerve and sixth nerve are essentially motor nerve, right?
Yes.
So,
There is paper also in cavernous sinus, so it can cause.
yeah, so usually a lot of times the first nerve actually that is going to be showing is not these nerves, it's more the
Yes.
sensory nerve. That's why the pain is always, you see, but, and does the pain fully resolve or do you think it remains even after treatment? What did your patient
Generally,
get?
mainly first the ocular motility was resolved. First, she has regained all the motility. Motility was not restricted, but the pain was little there. But it was after 1 month she has no pain.
Yeah, often the pain would tend to stay for quite some time, and that therefore but as the apex is getting more and more, obviously you want to give steroids. Even high dose oral steroids can do. Doesn't necessarily have to be
source of resolution? I mean, when did the diplopia resolve? When did the headache resolve? And in case the patient had persistent diplopia or persistent symptoms, what else would you have done after steroids?
Okay, first of all, the ocular motility were resolved, but the diplopia resolved after 1 to 2 weeks of the treatment, not suddenly. Suddenly, we can see the dramatic improvement, all the gauges occur. Like she has all the gauges different. But it was eventually, it was
So
eventually get
first, the extraocular motility
yes.
improved,
Then
followed by diplopia.
headache was resolved after 1 month actually, properly, completely
So
resolved.
the last to go was the headache,
Yes.
right? So if she was not very responsive to steroids, what else could have been done after that?
Actually, if she is not responding or problem to steroid, we can give immunosuppressive agents also.
Immunomodulators, yes.
Immunomodulators.
Azathioprine works well.
Azathioprine,
Yes.
yes.
Thank you.
Thank you.